Hey team, welcome from our apartment. It is Nina
And Eddie.
and Santa Claus. So today we're going to be talking about hip restrictor diagnosis and a couple different techniques you can do to address this in the office during your outpatient appointment. So first of all, we're going to get started and focus on the pelvis. For the pelvis, the diagnosis of choice is the standing flexion test. So some different landmarks I'm going to use on Edward here. For starters, the iliac crest you can palpate on either side, kind of get your landmarks. And then I'm going to inch my way down, and I'm going to feel for his PSIS, bony landmarks. And after that, I feel them here, and I'm going to instruct him to bend forward and try to touch his toes. And back up. So during that test, I can feel that his right side moves superiorly in relation to his left side. So that diagnosis would be a positive standing flexion test on Edward's right side.
Good. Seated.
Rolls about location of my hands.
Yes. So one important thing is to be consistent with this standing flexion test. So you want to be on the inferior edge of that PSIS, and you're going to provide a slight force upward, just so you make sure you're at the same spot every time you do a standing flexion test. Another important thing is that you have to realize that when you are asking your patient to bend forward, they will have to move their hips backwards. So don't provide too much force forward, or else they're going to be on their toes, or they're going to be face planting in the office.
Thank you, brother.
That's about it. You're welcome, sister. Hello again, class. Now we are going to talk about the seated flexion test. This test is used for sacral diagnosis, specifically because we have the patient seated and their hips are stabilized on the table, and we can get a better feel for how the sacrum is actually moving. So it really is the same exact process for the standing flexion test, the same landmarks. So, as you see, you have your patient sitting down, facing away from you. You are going to find the iliac crest, and again, just walk your thumbs back to the PSIS. Provide that slight upward force on the inferior edge of the PSIS. You're going to instruct your patient to bend forward and come back up. And you're really going to be looking for which PSIS moves superior first. So on Nina, I noticed that the right PSIS moved superior first, very slight, but that would be a positive right seated flexion test for the sacrum.
A good way to remember this is sacrum equals seated flexion test. S equals S.
Not to be confused with standing. We'll cut that part.
Hey team, we're going to talk about a treatment now. Do you treat runners in the office?
Yes.
Are you a runner?
I'm not a doctor, but I am a runner.
Cool. Well, your piriformis is probably having some somatic dysfunction. So let's treat it today. Does that sound like a plan?
That sounds great.
Awesome. So, to diagnose the piriformis, what I'm going to have Edward show us right here, just for a different angle. We'll go over it again when he's laying down. However, the piriformis muscle can be identified by first feeling for the landmark of the greater trochanter. So if you work your way down, again, from that ischial, from the iliac crest, down here, to the greater trochanter, you're going to feel kind of a bony bump right there. And so that's going to be your lateral landmark. Your medial landmark is going to be the inferior lateral angle. And so if you work your way down from the PSIS, you're going to hit kind of an end point of that sacrum, the inferior lateral angle. So this is where the piriformis attaches, and you're kind of going to inch your thumb into that inferior gluteal fold right there, and that is where you find a common tender point for the piriformis muscle, where we're going to perform strain counter strain. So I'm going to go ahead and have Edward lay down, face down on the table here. We're going to go through this treatment, highly effective. So first of all, again, you're going to palpate those landmarks. You're going to ask your patient for permission to do so. This is a sensitive area. So once you get into that piriformis muscle right there, kind of right in the central area of the buttock, you're going to ask your patient, is this a 10 out of 10 pain? Even if it's not a 10 out of 10 pain, you're going to rate the pain that they feel at the most severe to be 10 out of 10 for the sake of this treatment. Edward, is this a 10 out of 10 pain?
Yes.
Perfect. All right, so then we're going to do our best to shorten this muscle body. So by addressing the piriformis, shortening that muscle body, we're going to induce some hip extension, also some external rotation. And when you move this lower leg internally, the hip is actually going to external rotation, and so this is going to provide the most shortening of that muscle body. So you get a lot of patient feedback during this time. Edward, is the pain lowered to 3 out of 10?
Yes.
And so 3 out of 10 is going to be your magic number. You're going to keep modifying your angles here until the patient reports that that established 10 out of 10 is reduced to a 3 out of 10. And from here it's super simple. We're going to hold this position of the 3 out of 10 for 90 seconds. And during this time, I'm going to ask Ed to do some deep breathing for me to enhance the muscle relaxation. And I'm really going to hold pressure on this tender point in the middle of this piriformis muscle body. Go ahead, big deep breath in and out. And right now I'm just counting in my head from 1 to 90. What do you know? It's been 90 seconds. So then after this, I'm going to take the muscle back to where it was. And I'm going to palpate in that same area. Hey Ed, do you feel like this pain is reduced from what you originally felt?
Yes.
Great. That's a success for strain counter strain. It works a lot with neurofeedback and trigger points within those muscle bodies.
A few points with the piriformis tender point. That is where most people have their sciatic nerve coming inferior to that muscle. About 15% of people will have it coming through that muscle, so make sure when you are pressing on that tender point, you're not just shoving your thumb into the nerve. That's all I got. All right. Hello, class. Now we are going to talk about the hip restrictor, the iliopsoas. So again, as with everything, the anatomy is important. The iliopsoas is formed by two muscles, the iliacus and the psoas muscle. So that's the inside of your iliac crest, and then your lumbar vertebrae coming down to the lesser trochanter of your femur is the primary hip flexor. So a way that we're going to combat somatic dysfunction in the iliopsoas is using muscle energy. So we're going to ask our patient, do you have iliopsoas somatic dysfunction?
Oh yeah, I do, and I feel it kind of in my groin area.
That's great. So for muscle energy for this, we are going to have our patient lay on her back. And there are two ways to do this. One is you can have the patient scoot towards you, leaving one leg slightly off of the table. So I'm going to have you scoot towards me. And again, you want to make sure the rest of her body is stabilized. Right now we have this iliopsoas in its restriction. And remember, using muscle energy, we will have the patient actively contract towards their ease. Her ease would be up into hip flexion, while we are providing resistance and eventually progressing towards more hip extension, which would be her restriction. So again, with muscle energy, we're going to instruct our patient to contract her hip muscle up against our hand and relax. We're going to contract for about 3 seconds. We're going to not let her knee move upwards. It does not have to be a very big contraction. We want to just make sure we're using the right muscle. After the contraction, we're going to let her relax for about 1 to 2 seconds, and then we're going to push further into that restriction. And again, we're going to say contract and relax. So I'm not letting her move her knee at all. This is going to be in isometric contraction. Confirm or deny? All right? Yeah. Isometric. We're going to push further into that restriction. Contract. Relax. We're going to let it relax right there. And then we're going to bring her leg back up. So the book says 3 to 7 times. Really, you can keep going as long as you're making progression and the patient is willing to go. Another way to do this stretch is you're going to have your patient come all the way to the edge of the table. You're going to bring her non-dysfunctional leg up. You can stabilize that against your hip or just use your arm here. And it's the same idea. You have this iliopsoas in the edge of restriction right now. You're going to push just a little bit. You're going to have the patient contract up against you. Relax. Give it a second. Push further down. Contract. Relax. And so on. As always, deep breathing helps with this one as well.
And a good deep breathing tactic to instruct your patients is during the contraction, take a big deep breath in, and during the relaxation, big deep breath out. And oftentimes I will explicitly tell my patients, big deep breath in, big deep breath out, over and over again throughout the entire treatment. We'll cut there. And then I wanted to yes. Good there?
Yep.
Okay, good. Is it on?
Yeah.
Also, throughout the holidays, you may have a strenuous job, such as our patient right here. So you might want to, remember your suboccipital release, because all of us are very prone to carrying the tension in our cervical muscles. And so, again, that's this sort of idea that someone's seated like this at a computer or a sleigh throughout the holiday season. And again, like we reinforced last time, you're going to use your finger pads here to apply pressure right there on the suboccipital region, like so. And just incorporate deep breaths like we had previously with the muscle energy. Big deep breath in and out.
Sleigh bells ring, are you listening? In the lane, snow is glistening, a beautiful sight, we're happy tonight.
Feels so much more
Walking
relaxed.
in a winter wonderland.